Great. Well, welcome and thank you for joining us for our AAST monthly virtual. Good afternoon, everyone, and thank you for joining us for our monthly virtual AAST Grand Rounds. This month is National Wellness Month, and we are very excited to be joined by an incredible panel of trauma surgeons, friends, and colleagues from across the country to discuss a number of different topics as well as concepts, tips, and tricks for managing wellness, work-life balance, dealing with PTSD, and discussing resiliency, all in the background of some of the key social and political variables that oftentimes determine how we as healthcare providers interact with our patients and their loved ones. Just as a reminder, beginning in 2021, the AAST will no longer offer CME for live Grand Rounds. CME will be available for the archive version of the Grand Rounds. And those who watch today's Grand Rounds, you'll receive an email once the archive version is available on the AAST website to prompt you to log in and claim CME. So as I mentioned, we have a great group of trauma surgeons, diverse group from across the country, and co-moderating with me today is Dr. Paula Ferrada. Dr. Ferrada.
Dr. Kim, thank you so much for the opportunity. I think this is timely that we have this important conversations. It's an honor for us to have this wonderful group of people that have done a lot of work, not only in publishing, but internally in being role models and trying to make a change in our environment. I want to introduce Dr. Tanya Zakrison, professor of surgery, and she's gonna talk to us about her experience.
Yeah, and also joining us is Dr. Sharmila Dissanaike. I think everyone knows Dr. Dissanaike. We've had several great conversations in the past, and she's the University Distinguished Professor and Peter C. Canizero Chair at Texas Tech University, Health Sciences Center in Lubbock, Texas. Good to see you again, Dr. Dissanaike.
Thank you so much for having me, both of you.
And then the icing in the cake is somebody that is not only experienced, but has tremendous energy and has been able to mobilize forces to make, to actually bring the power where it's needed in political actions with Dr. Joseph Sakran. Thank you so much for joining us and devoting time to us.
Thanks so much, Paula.
Right. So just to start off, I wanted to just check in with everyone. Dr. Dissanaike, how are you doing in Texas? You know, things are obviously, it's like deja vu all over again with the COVID surge and pandemic and the Delta variant. So how are you and your colleagues doing?
So thanks, Tanya. So loaded question, of course, right? In every sense of the word. September 1, the handgun carry restrictions drop, and today school started with no mask mandate, no ability to put in a mandate. And we are already at the stage where our hospitals are full and we are curtailing some elective surgery as a result. And so things are rough. And my biggest concern is, you know, as we'll talk about, our team is already tired and we had a high burnout rate before any of this started. And we keep asking people to stretch. And I will tell you, this time compared to last time, we were distressed, we were afraid, we were fatigued. This time, the good news, and I'd take this version any day because people are not as worried because we're vaccinated, right? So our personal fear for ourselves and our families who are above 12 is not as great. But my team that have young children, they are really worried. They can't send their kids to school with masks because they'll be bullied terribly if they're the only ones in class wearing it. They don't know what to do. They can't keep them at home because that's not fair to their social development. So I really feel for a lot of our team has young children, and that's terrible. Below the age of 12, they don't have the vaccine yet. One of my colleagues is driving to Corpus Christi, which, if you know anything about Texas, it's way south. That's about a 15-hour drive to get those kids in a vaccine trial. So, you know, it's really rough. And then there's anger, right? So on top of all these sentiments, if you think about it, I've already listed a whole bunch of burnout symptoms right in that description. That's what our people are feeling. And so I am worried about the team and going through this surge and how many more surges will we have to go through.
Yeah. And as the chair of the Department of Surgery, what sorts of measures or interventions have you put in place to check in on your surgeons and make sure that they're doing okay and being able to cope with what's going on right now?
So one thing I do try to do, and this sounds very trite, but I really do try to at least keep them updated. And I do a lot of the basic updating by email and just write to them and let them know what's going on, because people need to know. They don't want to be kept in the dark. So at least they're forewarned. That's a simple thing I think a lot of chairs of departments are doing. One of the difficulties is I don't want to gather us all together in a room and risk contagion, right? Because we're all vaccinated, but we know we can spread it. That's really been a challenge for me, because I want to meet with people one-on-one. But so far I am doing it one-on-one or in very small groups. I meet with the residents in groups of 6 or less. Faculty, I meet one-on-one, and I'm dropping by offices, wearing my mask all the time. If they choose to take it off in their office, that's on, it's their choice, but I wear it because I don't want to ever make people feel uncomfortable. And I'm having to do one-on-one check-ins because I don't think it's safe to gather the whole department in one room. So yeah, I mean, the nature of this challenge makes the remedy even harder.
Yeah. And Dr. Zakrison, we've talked quite a bit about resiliency as well as wellness and burnout among surgeons. And as you've mentioned previously, almost 2/3 of trauma surgeons surveyed have at some point in their careers felt burnt out. And so these kind of terms go around so commonly: burnout, wellness, work-life balance, resiliency. How do we make sense of this sort of conceptual framework, and how do we apply it to our everyday life at work?
Thank you, Dr. Kim. And, that's an interesting question, because I think there is a lot of terminology that goes along with this. I think we have to divide the terminology with the whom is being affected by this. And you're right, surgeons do experience burnout. I think also what you're alluding to is, in particular, trauma surgeons, in particular in the United States, are now experiencing 61% burnout rate, which is not normal. That's not normal, because you don't see transplant surgeons experiencing this. You don't see other surgeons experiencing this. They work hard too, they're exhausted as well. So you're right, there's burnout versus moral distress versus moral injury versus psychological trauma. And they're all compounded, in some, like the moral injury, are, for example, when I can't do the right thing for my patient, and it comes from the military literature. But I think, sort of putting that aside for a second, if I may, I think the key thing about burnout is being careful about the industry of wellness, where there's all these courses and things. And I'll be honest with you, and you can feel free to kick me off the panel immediately. When I hear wellness and mindfulness and all that, I want to scream, and I delete the email, and I do not attend the meeting, because it's just more, things on my schedule of things to do when I do not have the time to do that. So there's a bit of that. I think it's very important for us as trauma surgeons to say, what is happening in our profession? What are we bearing witness to as trauma surgeons in the United States that is hurting us so much? That would be the key question. And what can we do about that? So that really, I think, drives that. And if I may, just to wrap up, it's that parable we all know of you're walking by a river with your friends, and you see these kids falling in the water, and they're drowning in the river, and you run into the river and you pluck them out, but then more children are drowning in the river, and you pluck them out over and over again. You get exhausted after a while, you start to drown yourself, until you go upstream and you say, why do these children keep falling in the river, or why are they being pushed in? And you solve that problem. So I think it's a bit complex, but I think I would posit that it's very unique to American trauma surgeons. And I'm just quoting, again, Carlos Brown's work, and Bilal Joseph has actually looked at this on a global level too. So it's their great work that they've done. Thank you.
Dr. Zakrison, can you comment briefly about what are your thoughts in how burnout affects the level of compassion exhaustion towards our patients and our team and ourselves?
Yeah, it's a great question, because again, we know, I mean, even again, without the terminology, which I'm not as familiar as I should be with it, I can tell you what it feels like being on call. And I'd love to hear from, my friends, to see if this happens to you as well. Is like, I'm on call, we can have medical students that are actually like first year medical students to residents of all backgrounds. We have new trauma techs and trauma nurses. I'm literally just trying to keep everyone alive, like quite physically, trying to keep the patients alive. But I have to remember, oh my goodness, this is the third like traumatic arrest that we're witnessing. Actually, the other day on call last week, I was on trauma. We had like 2 high school students that came in, you know, and with the added angle that both of them were young women who are African-American, and they're seeing death upon death, shooting upon shooting, specifically here on the South Side where I work, of young African-American men and some women, and now some older people too. And we even had a neonate shot in the head, like on the July 4th weekend, and it goes on and on. It is so hard, that compassion fatigue to, I want to say, I think towards the patient, that's like the last ATP molecule I have left will be for the patient to just hold their hand and say, we're gonna take great care of you. No one deserves to get shot. And then they frequently start to cry, and we all start to cry. But it's very hard to have that compassion to our trainees that are bearing witness to such trauma. So I don't know if that, you know, makes sense, or if I'm explaining myself. I don't know if, and I would ask, like, have you felt that, Paula, and have our friends felt that too?
Yeah, no, of course. I wanted to not to take it away from Dr. Kim for a little bit, but ask Dr. Sakran about this precisely. We were talking before about psychological safety and how does it look like, and how we provide it for ourselves, and how do we provide it for our team, and how do we ensure that, you know, because surgery is all like, we need to be super strong, right? And we need to be tough, and we have to have a thick skin, and crying in front of a patient, what a rarity that will be, and how it will be looked around other people. And how do you understand that showing emotion is part of being stronger, and part of healing, and, you know, with how the trauma impacts us psychologically in our trainees, and how we're allowed that to happen, but also how we react, and how do we allow processing from complications and things that of course shouldn't happen, but that will happen when we're in training. Dr. Sakran, what do you think?
Yeah, well, thanks, Dr. Ferrada. And it's great to be here with all of you. And I'll just say, I feel a little bit funny, you know, having this session, talking about burnout, because I was on call last night. I worked all day, and here we are. And, you know, sometimes we're our own worst enemy. And, you know, specifically to your question, Paula, look, when you think about this term that we're seeing used quite a bit now as it relates to psychological safety, I think what that means is really a shared belief that's held by members of the team that other folks on the team are not going to be rejected, embarrassed, or punished for speaking up. And I think that this kind of relates to a lot of the different aspects, whether you're looking at it specifically from a patient outcome perspective, and you're in the operating room, and, you know, trying to kind of really have a really flat level of hierarchy, so to speak, in order to ensure that if someone in the room sees something that's not right, they're able to speak up. And I think developing that type of culture is critical. But then, you know, the second part of all of this, as you're talking specifically about us, right, it really, I think, embodies, you know, what we're seeing on a daily basis, especially as trauma surgeons, right, where we have, you know, young, you know, men and women that are coming into our trauma centers that, you know, are being injured and killed. And the reality is that healthcare professionals face the risk of traumatic events, whether it's an unexpected death, whether it's a medical error, whether it's an unplanned transfer to the ICU, right? But we don't have enough programs to support us, right? And so there's this term that Dr. Albert Wu from the School of Public Health actually coined. It's called second victim, meaning, you know, the first victim is the patient that you're taking care of, but that second victim is us, the healthcare professionals. And I think often, you know, we experience, you know, self-doubt, burnout, other problems that can cause significant personal anguish and hinder the ability to deliver that compassionate care that you're talking about. So at Hopkins, for example, we have developed a program that is a peer responder program that delivers psychological first aid, essentially, and emotional support. The program is called RISE, and it stands for Resilience in Stressful Events, right? And it essentially prepares healthcare workers to be able to provide skilled, kind of non-judgmental and confidential support to individuals and groups. So this is just one example. I'm not saying it's the only example, but I think that we have to be cognizant of that. And this goes back to what my colleagues were saying, which is, really, embodying a culture that allows us to move beyond, frankly, the inability that if you're, having an issue, whether it's a mental health issue or whether it's just struggling with a patient care piece, it's not weakness to speak up. And I think that really requires a cultural shift, which takes time.
One of the things that I'd like to contribute to this is we've all known some of these data for a long time, right? I mean, burnout is not new. We've been talking about it for 20 years at least. I think one of our problems as a community of surgeons, of physicians, and trauma surgeons in particular, is we are all subject to multiple stressors. And I think sometimes we kind of lump them together. So for example, for one person, watching preventable injury after preventable injury is a huge source of moral anguish. For another, they may actually be kind of, okay, well, I didn't cause the injury, I'm fixing it. That may not be their trigger, but maybe when they cause a complication and it's sort of more on them, that's a really hard burden to bear. And maybe they don't know how to talk to colleagues about it, or they don't have colleagues who can listen non-judgmentally. For another group of people, it may be that, oh my gosh, I'm captain of the ship. I have to look after this really sick patient and I'm really stressed and I'll never be mean to the patient, but I'm going to turn around and be really snappy to every nurse and every student who's in there, right? And you all are smiling because you have seen every single one of these personas, and you've been probably every one of the personas. I have every single one at different times. And I think those are different stressors that have different stress responses that all lead to burnout. But until we individualize a little bit to say that any of these could be the stressor, but here's a solution, we're not going to make a huge amount of progress, because I think it is so variable based on where we practice. But, Tanya made the interesting point that it is an American trauma surgeon problem. So there are some commonalities. But I think we shouldn't lose the granularity. I would hate for us to come with one answer, which will end up excluding a lot of people.
So
I just add something to that real quick.
Sorry, go ahead.
I think it's not only, I think it's such a great point. And it's not only the fact that there's different triggers for each individual, but it's also the fact that different individuals deal with grief in different ways. So, for some people, I try to do like a debrief post, a really bad situation. That doesn't work for everyone. Some people have to take time, and they have different ways to deal with that grief. And I think that's also, it can be difficult, but also important to recognize.
Just one brief thing that I was going to say is that the burnout might be worse in people in surgeons, American surgeons in the United States, specifically also women, because we have other responsibilities. Sometimes we have other responsibilities that go above and beyond work. But I think burnout also happens in Latin America and also happens in Europe. It just happens differently. It's very individualized. It's not an answer for everything. I think one thing that I'm going to say for anybody that is listening to this is what has helped me is not feeling isolated. Is that don't think that you're the only person that this ever happened to. Don't let yourself be put down by shame, because sadness and feeling guilty and complications happen to everybody. And how do you teach resilience, right? Let's go to another workshop in wellness instead of being with the family. Probably not going to help much. But I think it's really hard to teach resilience with a PowerPoint slide. I think it's like an experience and one-on-one person. But I think it's super important not to feel isolated.
And just if I may add to that, Paula, I loved what you said, and I hope no one minds if I use first names, just because I know and love you all and you're too close to me. But you're right. I think, and also Sharmila, you said this too, like, and everyone said this, Joe as well, like we process grief differently and loss and pain and hurt. And the way I process with my it's all political, like that's not going to be everyone's way. I wish it was, but it's not. It's just, we're all different human beings. And so that's why that cookie cutter, do this, do that won't work for everyone. We have to be able to have the space, which means time off work, to be able to find what works for us. But I think it's also interesting. It would be interesting to maybe actually Bilal Joseph, I don't know if he's one of the participants or something, but I would love to read his study. I think he's submitting it now about global trauma surgeons and burnout, Paula, because that's, I'm very jealous, by the way, that looks like a beer, but I was gonna say it's interesting because, my husband lives in Havana and he's a trauma surgeon, general surgeon in Havana, and that's a whole other story, but the support networks that people have are different, and many surgeons actually live with their families, like multi-generational families still, and that's pretty common around the world. We tend to do that less in Canada, Dennis, in the United States. And I was talking with a colleague at the University of Chicago I just met in a Zoom meeting. She's a psychologist, and we were talking about grants or whatever, and an amazing woman. And she was telling me about her amazing children scattered all throughout the United States with very successful careers. And I thought, that's wonderful. But on the flip side, maybe you just want to get together and have dinner together. Like maybe we're missing out on sort of a socio-cultural level that other parts of the world have. But with that said, of course, there's burnout everywhere else, even if that term might not be used. And another angle I just wanted to add to that, something that we're kind of tuning into at the University of Chicago, is not just like, what's the impact of seeing all this homicide and preventable death, particularly for Black and Brown communities, on our trainees, but also our faculty who are Black and Brown, and and surgeons of color. But we also have like a lot of military medics and Army surgeons that are rotating with us for 2 to 3 years or so. And the violence they're seeing is actually, sometimes even worse than what they've seen on deployment. And it's just kind of bonkers that we don't have automatic support for people, for fear of like, what if we're reactivating people's PTSD? And, how are you doing with this? And, I just want to go to what Dennis is setting up nicely. We wrote a chapter on this, and we interviewed our trainees and our residents at the University of Chicago to say, hey, how do we do wellness? How do we teach resiliency at the University of Chicago or for anywhere, especially for the residents rotating on trauma? And Dr. Oyeni had a really interesting, response. And he said, I do feel trauma surgeons of color are disproportionately impacted by the stress of continuous trauma exposure. On the south side of Chicago, the overwhelming majority of violent penetrating traumas are against people of color. And this forces trauma surgeons of color to see themselves and their patients and feel their pain on a deeper level. Again, it's concerning to me that we have no support specifically for that, specifically for bearing witness to that preventable homicide and mortality. Many times when a trauma patient rolls in, I see my friends, I see my family, I even see myself, says Dr. Williams. Again, powerless to stop the vicious cycle that makes trauma centers across the country seem like revolving doors. And again, we were alluding to this earlier, it's that ongoing revolving nature of it. And this is sort of the last quote slide from the African-American perspective. And what hurts me the most is my powerlessness to stop the cycle. I think many of us became surgeons for some instant gratification to have a direct impact with regards to healing patients. With trauma and that powerlessness, we aren't seeing that gratification. Sure, we stopped the bleeding, reinflated the lungs, and closed the hole in their stomach, but we didn't cure the disease. And what's exciting is that trauma surgeons are asking the question, what is the disease really? What is that upstream cause of the disease? Lindsay Zhang, who is one of our residents, who has been a phenomenal surgeon scientist and looking into issues of discrimination and sexual harassment and residency across the nation, actually wrote this very moving opinion piece in the Journal of Surgical Research about what was happening during the time of COVID for our Asian American trainees. And she states that this profession is more than work, it is a calling. But when patients refuse to be seen by anyone Asian looking, and when care and concern is met with bigotry and hate, it is an understatement to say it hurts. So it's interesting that we're only now, I feel, tapping into that pain. That's racial trauma. And Paula, I mean, we've talked about this a lot. Like, we've had, panel sessions on this. That's another layer of pain that I think we're learning to develop the language to address for our own healing, and that also of our patients disproportionately affected. Thank you.
I think to follow on to what Tanya was saying is support structures are also, she talked about family, but I think, so maybe this is just me, although I'm sure it's not just me, is that I feel like the only people who really understand what we go through are our colleagues, our other trauma surgeons. I mean, I love my family, but I would never sit there going over details with them because it would be too tedious to have to set the background, right? I mean, it's impossible to put into context, whereas I can talk to my colleague and there's no context necessary. And I do think a big variable that we have not really ever measured, I haven't seen a single paper that really measures this, is how much non-judgmental support do you have? And I think if there's anything that leaders in surgery, not just chairs, but division chiefs and heads of trauma surgery need to do, and I know this is a question that's going to come up, I think that that's probably one of the most important things, is that you need support, not just in terms of how you set up your call schedule and how you set up shifts versus 24 hours. You can do both either well, both can be done well, but how do you set it up so you're not exhausting people? How do you make sure they have backup for when they're tired? And how do you make sure that everyone supports each other non-judgmentally, so that they have that built-in network? Because I actually think that's probably one of the most important things. And again, it's very hard to quantify, right? Because how do we measure it? Everyone's got colleagues, sure, they exist, but some of them can be more harmful than helpful. I think that support structure is just as important as the hard pieces of how much do you get paid for call and how often do you take call. All of it's important, but that psychological team mentality to me is priceless. I mean, honestly, for me, my colleagues who cover for me right now, I'm on call. Someone's covering for me without batting an eyelid. And they're wonderful and fabulous. And I wouldn't trade my team for the world. To me, that's probably what keeps most of us sane most of the time.
I think those are great points, and I know Joe has a comment to make, but quick question for you, Sharmila. So let's say you're a junior attending, or you've just changed jobs, and so it's a completely new group of trauma surgeons, different hospital, completely different culture. How do you navigate that and feel safe to be able to cry, to be able to kind of have a debrief and break things down and be able to let your emotions out without feeling vulnerable or without feeling judged?
So the answer to that is hopefully you figured that out before you signed your contract, right? I will suggest it's a lot harder to figure it out afterward. And this goes to the point I tell all my own trainees and everyone really, you will earn a salary that's fine. Like, I don't think any of us as US trauma surgeons are paid poorly. We could all probably think we deserve more than we get. That's like universal, but get a decent salary and then spend all your energy finding a good team, right? And you need to figure that out before you ever sign that contract. And it means asking that question. It means going, hey, when did you last have a complication? Did you tell your colleagues about it? What's M&M like? And I would really investigate that culture, because here's the reality. You're not going to change that culture as a junior attending. So you better choose wisely, because the odds are that if you don't, and if you find you're not in a supportive culture, and if the first thing that happens after a bad outcome is you are being dragged in front of peer review and your colleagues are piling on to how crappy a surgeon you are, that isn't going to end well. And I see this all the time. So as you might know, I have a lot of hats, and one of the hats I wear, I'm on the Texas Medical Board. So as you know, Texas is a malpractice tort reform state, right? So it means that lawyers find it very difficult to sue people. And so instead, a lot of complaints go to the board. So the board has more authority, including to revoke your license. And so, it's really eye-opening how some systems are supportive and some are not. And that becomes very apparent when you're in that role. And I see it everywhere. And I will say that sometimes it's the individual who clearly is not working well in the system, but a lot of the times it's the system, and you need to find that out before you sign. because honestly, Dennis, afterward, you're not changing that culture. The culture is what it is, and your best bet is now to adapt to that culture till you get into a position of authority, and then you can change it. But your first few years, you're not changing culture there, mostly.
Yeah, appreciate the insight. Joe, you had some thoughts or comments?
Yeah, it's been a great discussion. And as I'm listening to the discussion, one of the things that I think, we haven't done is really define what burnout is. And I think probably because it's a little bit difficult to define because there's so many definitions out there. But what I found is there's a couple, I would say, just pieces that are very common across all the definitions. I think the first is that individuals have emotional exhaustion, right? And I think that is pretty a standard with most of the definitions that we see. The second is this like feeling of depersonalization. And we've heard a lot of this discussion tonight about this. And then the third that maybe we don't always think about is this kind of low sense of personal accomplishment in association with kind of chronic occupational stress. And you think about us as trauma surgeons, right? I mean, of course, I think all surgeons are probably, or all medical professionals are probably type A. And then you take like the surgical group, or probably even more type A in general. And we put a lot of pressure on ourselves, right? This whole like idea, of this like tripartite mission of like being a clinician, an educator, a researcher, right? All these things. And I think we've moved on from that to really thinking about it more as a team or a department, right? How do we make the department, a tripartite threat? So I've seen this personally where, you have folks that are like total superstars excelling, but they believe that they haven't personally achieved X, Y, and Z. And part of it might be imposter syndrome, but part of it might be that they're so beat down by everything that's happening that they don't even have a chance to take a step back and see what other people can see from outside their own vantage point.
Yeah,
I think
sorry, go ahead.
Go for it, Paula.
Yeah, no, I was thinking about since what Sharmila was saying and completely agreeing with Joe, I think it's true. You have to investigate the culture. You have to investigate where you get into it, but you can do great investigations and have all the data and join a place that can change. Like the boss that you sign up to like be with because he was a great mentor retires, for example. Or there's a new chairman or both, or there's a lot of other things that can happen. So what do you do then? I think you're right. You're not going to be able to change the world one person at a time, right? But there's a lot, but if you're feeling it, and I think a lot of places that are toxic that have this culture can do a little bit of gaslighting with individuals. Oh, everything is great, and then yet the residents are hiding M&Ms back and forth because they don't want to expose what's happening because they also are afraid. And I was talking to Tanya about this not too long ago. Is this sentiment where people feel persecuted, where they're prey, and look at it in the animal kingdom, right? You have predators and prey, and prey usually they don't get together and like do something radical and change the culture. No, the prey is like running around trying to hide. That's why the prey that gets eaten is usually the weakest. Is the older of the group, or the baby of the group, or the one that is already injured, right? But we are not animals, and we have higher thinking. And is for so long that people can take bullying and feel like prey. It's not only until you get allies, true allies, that you can protect each other, and you can feel that you can stand for something that is fair, not only for yourself, but for the people around you.
I would just, if I can jump in, I would just say like, Paula, I agree with you 100% with everything, you said. And I think it is important, even no matter what level it's happening, if one is seeing kind of really not great behavior and sort of injustices locally and all that, then probably several people are feeling the same thing, and there's ways to address that, and that's important. But I think it goes back to what people were saying, and how do you create that environment of psychological safety where you can be vulnerable, where you can go knock on a colleague's door and just cry on their shoulder, and they can do the same with you. And it's interesting. I think a lot of that does come from leadership. If you're fortunate enough to find that leadership, and you're right, Sharmila, sometimes you just have to leave your institution and find the leadership that works well for you in terms of the culture and the language that's utilized. But it's interesting. We're doing this at our own internal division M&Ms the other day, like the culture is sort of like, we talk about the complication or whatever, but then the surgeons who the surgeon's complication, they're the first to comment, and you hear them say, after the resident presents, I think where I could have done better is this or that, but they're always given that space to comment first of all. And I think the way the communication is done is just so interesting in terms of how do you build up that quality improvement area and really fix it on a systems level. And I think that's important to build that psychological safety amongst everyone, but being intentional about that, to say, like, let's have interesting ideas outside of the box. Let's think of this, let's think of that. And somehow, hopefully in the future, we can shift, our collective culture of trauma surgery around the country. So it's not just M&Ms, it's not just, quality improvement, where we're talking about all these, bad things that happened. We don't actually normalize the good saves. There's no format for us to get together for the positive M&Ms, whatever the opposite of M&Ms would be in that land of like, wow, what a great save. We have like grand rounds and stuff on a national level, and no one wants to go to another meeting. Let's be honest. But the great saves, that's just our regular, day-to-day stuff. We don't really even celebrate it. And we should. We have to remember that. I think I was talking to a colleague about this even just yesterday. But yeah, I agree 100%. Thank you.
I think one of the things is that, one nice thing is if your overall structure, your hospital celebrates trauma services, which the good thing is a lot of our hospitals do, very often, level 1 trauma center is the jewel in the crown, right? Or at least it's one of the jewels in the crown. I will say that our saves do often get celebrated, right? There'll be a little media release. Everybody knows it's dramatic, right? You can't have a really badly injured trauma patient who rushes to the OR and then ICU, and we do a lot of work and save them. Half the hospital kind of knows about it, or at least in that vicinity. So one of the advantages we have perhaps over some of our colleagues is some of our saves are celebrated, but at the flip side, one of the things as I was listening to you all, you're right. I mean, definitely change has to start somewhere, and everyone getting together collaboratively and making that push is crucial. Nothing changes without it. One thing perhaps that puts us at a disadvantage is that the trauma team is not just surgeons, right? There's like a million other people, other specialties. So I wonder if one of our problems is that to do a lot of good, we have to get a bunch of colleagues in other specialties, some physicians, some not, and maybe that makes it just a little bit harder because we do work day to day in perhaps almost a more multidisciplinary environment than other people do. Now, this is a positive thing. It's where everything is going. So it's not bad by any means, but it does mean we need even more coordination, perhaps, to try to improve the system. And again, I don't know, because a lot of our studies focus exclusively on the surgeons, right? We don't take it where we analyze the surgeons' burnout right next to the nurses' burnout and the orthopedic surgeons' burnout, perhaps. I've not seen that. And I'd be very interested in the same institution to see, is there a difference, or are we just measuring institutional burnout, or are we truly measuring trauma surgeon burnout?
Joe, you had a thought or comment?
Yeah, I'm thinking about what Tanya said as it relates to, psychological safety and how we do it. And I think there's like a number of different, principles that people talk about as we're trying to like change this culture. And I think the first is, really making it an explicit priority. And a lot of that begins with, folks, including leaders, modeling the behaviors that you want to see and set the stage by kind of showing empathy in the workplace and showing the willingness to put yourself out there. I'll never forget, I have this, just very vivid memory of when I was doing my fellowship at Penn. And one morning, I don't think you'll mind me sharing this, but Pat Riley walks in to morning report. He had been on call the night before. And he was just like, you could tell he was a little bit anxious. And I was the attending of the week. It was our second year. So we're, what we call fellows and exceptions. So we have attending privileges. And I'm sitting at the table and I felt him behind me. I just felt him moving around and he's anxious. I'm like, what? What is going on back there? And he, like, at one point, as we're discussing the patients, he speaks up and he starts talking about a patient that he took care of overnight where he made a mistake. And it's a room full of students, nurses, residents, fellows, other attendings. And he was like, he put himself out there in front of the whole group to say, you know what, like, here's this patient. We totally missed this. We made this mistake. This should have never happened. And it was one of those moments that I'll never forget, because here you have the person leading, the trauma center that is showing and setting the example for everyone else that, we are human. It's okay. Like, we make mistakes and we have to have the integrity to be able to talk about it in a way that's open so we can learn from these mistakes. And I'll never forget him doing that and how, important he felt it was to share that experience, where many people might have just kind of sat in the back and they don't really want to talk about it or address it.
I was gonna say, Joe, that I think that is amazing, and I think that the people that I admire the most, these great leaders that have like all this amazing knowledge and have great careers, are people that also are able to show their vulnerability, not only in terms of patient care or complications or understanding that they're human, but vulnerability as in, it's okay to fail, it's okay to make a mistake, because if you don't allow yourself to make mistakes, then you can't grow, right? It's really hard to fill a glass of water that is already full. If you're perfect, if you think you're perfect, and if you don't allow yourself any mistakes, this is your plateau. That's where your career or whatever is it that you're seeking ends, right? It's only until we'll allow ourselves to fall, so you can get up and keep walking.
Yeah. Tanya.
Dennis, you're always such an amazing host with all these things. I want to know, what do you think?
Well, I've really enjoyed the conversation so far, and I think there's been some really important concepts and discussion that's been had. And when we talk about burnout, and Joe kind of talked about the chronicity of it, the depersonalization, and with Sharmila kind of talking about, what is the impact on the actual trauma surgeon versus other members of the team. We also do debriefs. We also have what's called Helping Healers Heal program for when we have a traumatic event and we need professional help to be able to sort of sort through our emotions and have a safe place to kind of decompress. One of the things that we've been doing that I think has made some positive changes amongst team members, nurses, doctors, anesthesiologists, trauma, radiology techs, is when we do have that unfortunate patient whom we can't save or who ends up dying in the ER. It used to be that we just kind of, called the time of death and everyone just took off, and literally there would be the junior resident left to close the chest. We actually hopefully can have an ID on the patient. We actually take a 10-15 second pause, just like we would do when someone's going for an organ donation. You want to pay your respects to a fellow human being and to be able to process what happens. And as was already mentioned, not everyone takes to that, but I find it is a way where everyone who's already involved in that trauma resuscitation can kind of participate and pay honor to our patients. But one of the things I wanted to kind of get onto, talking about chronicity, and I know last year when Bilal and Jamie were talking about sleep deprivation and stress and PTSD, like Joe's on his 36th hour, I'm on my 32nd hour. I started like 0500 yesterday, still going strong. I don't feel like I'm in a great spot right now or space.
Strong is relative, right, Dennis?
Right. So, you know, I was reading in the general surgery news, I think in June, Dr. Dissanaike, you were talking about how your ACS trauma service has kind of made some major changes and the impact that that's potentially had on your trauma surgery group. So I'd love for you to be able to share that with the audience and tell us how you made that happen. And is that really better than what most of us, I think, in the US are still doing, which is call?
Well, as I was joking, the whole going strong is relative, right? You're going, you're still going, but you know, it's at cost. So one of the quotes from that article was that I think the trauma surgeon, you know, no, we'd never let our patients suffer, so we take that hit ourselves. And I really do believe that. I think that when we are tired, we compensate. And we do so, and you know, Jamie Coleman's work has definitely shown this, we do so at our own expense. I don't think there's a way not to do it. And obviously, you know, if you take call overnight twice a month or something, sure, it's probably not a big deal. But most of us are doing it much more often than that. So, you know, it's now been about 4 years. I will tell you, we definitely had teething trouble, you know, because we were figuring this out. Other places had models, they're all different. So a few things, you do have to individualize. It's based on your volume, how busy you are, how many people you need, what are you covering, how many services, right? So you've got to kind of, it took us a while to work the math out perfectly, honestly. But we kind of did it gradually. That helped us. We did half the month on a shift work basis, the other half on conventional trauma call, and then we kind of gradually folded it over. The bottom line is not a single one of my faculty is willing to go back to 24-hour calls. So if that answers the question for you, during COVID, we actually floated the idea and they were like, oh, no, we'll find some other way to make this work. we're not going back. So they would not. And I will tell you, you know, I'm on call, but I finish at 7 p.m. and done. And there's just something, even if it's a night shift, there is something about being done in 12 hours, and then we have no obligations, you know, unless you choose to pick them up. And people are encouraged not to post shift, whether it's a day shift or night shift. And so, you know, I think sometimes you have to sort of draw a line in the sand. And the line in the sand that I drew all those years ago was, this makes no sense. No other profession thinks this would be a logical way to run things. And we just need to say, no, we're too busy. We're an incredibly busy level 1 trauma center, verified burn center. All these patients from a 250-mile radius come to us, and they deserve a doctor who's fresh and ready, and we deserve it. And truthfully, the motivation was us. I looked at the data. I knew there wasn't great data to support patient safety data. So I made it explicit. This is not necessarily about making things better for patient outcomes in a measurable way. It's about preserving surgeons. And it was very interesting to me that the admins got it immediately. None of the admins questioned it. Now, we may have negotiated how to pay for it, but nobody questioned the fundamental premise. The only people that questioned the premise were trauma surgeons, like literally the only people who thought, no, this isn't any better. We can keep doing this. And that was really fascinating to me. I didn't expect that. And it still remains to this day that the only group that's ever questioned it is that. And I'm not saying it's the only way. I think for lower volume centers where you get to sleep most of the night, yeah, the call makes much more sense. But for a busy center like ours, and I would argue most people on this panel, I think you have to draw that line in the sand, that if you're going to be paid for a full-time job, you should be doing a full-time job, not a day job and then this extra busy job layered on top, which you get call pay for. Great, but does your body and do your telomeres know that you're getting call pay so they shouldn't age faster? Does your DNA figure this out? No, it doesn't. So let's quit kidding ourselves that we can just keep stretching. We're human. We've heard that a bunch of times, right? We're human. And if we're human, it means that stretching ourselves is not an indefinite phenomenon, and it's not worth that extra pay. And that's just all there was to it. And so we made the switch. And like I said, our team wouldn't go back. It took some logistics. We were short-staffed, including during the pandemic. That hurt us. I burnt out. Most of us burnt out. It was rough. But now that we're up to full staffing, it's a really pleasant, supportive environment to work in.
And so I think any discussion on physician wellness, especially during this month, I think would be incomplete without talking a little bit about physician suicide. And it's not a secret. Every day in this country, there's a physician who dies from suicide, and the rates of suicide among MDs is 2 times that of the general population. And so I don't know if anyone has any stories that they want to share from their workplace, but what can we do to help our colleagues who might be at risk? How do we recognize them? And what do we do to prevent these sorts of tragedies?
Well, Dennis, I'll just say that what you're articulating is such an important point. And I think, all of these things, they're not disconnected, if that makes sense. Burnout and suicidal ideation and all these other factors. And how you compare what is happening among healthcare professionals to the general population is absolutely accurate. And in fact, there's also a gender difference. So when you look at like male physicians, it's 1.4 times higher suicide rate than the general population. But when you look at women, that rate is about 2.2, something around there, higher than the general population. And we have seen examples, especially, during COVID. I think a lot of you probably remember the story of Dr. Lorna Breen, an emergency medicine doctor who'd been treating COVID patients in New York, who herself contracted and recovered from COVID and then died by suicide. There's so many of those examples. And we've had, as I think many of you know, a recent personal example here at Hopkins. And, I would say without really discussing any of the details, because I don't think that's important to the conversation, I'll just say this is a lot more common than we think. And when you think about, the kind of whole spectrum, right, that exists, I think there are a number of people that perhaps are genetically predisposed to die by suicide. And when you ask yourself the question, well, why don't all those folks progress to that kind of end result? And I think a lot of it has to do with environment. There's a lot of data around this. And whether those environmental stressors are personal or professional. And when you think about, us as a community, the people that know you the best are the people that spend the most time with you. So that's, of course, your families and your loved ones, but also your colleagues at work. And I think there has been this stigma of really wanting to talk or discuss this issue. My brother's a child psychiatrist, and we talk about it a lot about how people don't want to discuss this. They don't want to talk about it. They're embarrassed. They have all these reservations. I think we have to break that mold because we have people around us, probably some on this webinar, that are suffering, right? And when you look at just what's happening in healthcare, especially with the pandemic, we have folks that are literally, quitting left and right. We have folks that are killing themselves. I think we have both an opportunity and the responsibility to think about those around us and look for those kind of warning signs and really try to intervene and be open in having those conversations. Because I think those conversations can sometimes save a life.
Yeah. Tanya?
To add, I mean, Joe, what you said was so eloquently on the mark. I would just add also, of course, we have to be there for our friends and colleagues and support them. But this is such an important issue that this has to be formalized, like across the country, across the world. I would offer, we had, what was it, like maybe within the past year, actually, Dennis, one of the neurosurgeons at the University of Toronto committed suicide, and it was a big surprise. No one knew, had the, perfect family and perfect life on paper. But again, I think this could be an easy fix tomorrow if we wanted, through leadership, CEO level, the C-suite and all the hospitals. I think all trauma centers, level 1, 2, 3, anyone that sees trauma and the secondary injury and secondary trauma that comes with it, like our job is traumatizing to us by definition. But we need trauma psychologists working with us, taking care of us, not just our patients, but taking care of us with a check-in every once a month or whatever. I tried to do that here in Chicago to get a trauma psychologist, and it's like $140 an hour. We end up talking about politics, big surprise. But like, it's fine. But then, like the July 4th weekend, I think I alluded to that. We had a 1-month-old baby shot in the head, and then literally 4 hours later, a 9-year-old girl shot in the head, and then 16 hours later, a 22-year-old woman shot in the head, in between all the multi-system traumas and all that. Oh, and then, by the way, someone shot up a car in front of our hospital. We went on lockdown because the shooter was somewhere inside the hospital, and I was just backup. I wasn't even active. And I know, like, Ken Wilson was in the OR operating, I don't know, for like 48 hours straight or something like that. That was hard. So we have a trauma psychiatrist that we call on an as needed basis, but that's largely because he's a friend, and he's like helping us out of just to be a friend and screening us for depression and anything that's like a concern. And we do reach out during those hard times, but this has to be formalized. This is not a mystery. We know burnout is a problem. I would just, offer, why not have one trauma psychologist for every 5 active trauma surgeons that are working, and then check in from time to time. And yes, we all treat trauma differently and stuff, but I think it's a resource that's very important to have some professionals saying, thumbs up, keep doing what you're doing, or maybe this isn't so helpful for you, maybe this is. I just think it's wildly supportive. That's what I would offer. We had, a pilot program of that for our residents, in fact, as well as faculty, and it worked actually very, very well. Thank you.
Thank you. Yeah, and I think I speak for all the members of the panel that I would second that as well. I think I would encourage everyone that's participating in the webinar or grand rounds to really go back to your home institution, talk to your colleagues, and ask around. If you're not already aware of what resources are available from a psychiatric standpoint, figure it out and really consider investing in these resources. And just from a personal note, a couple of years ago, I was going through a really difficult time, death of a father, together with then having to care for a spouse of a partner, in which the outcome wasn't that great. And, when you talk about having partners and colleagues who are there for you, I literally showed up on a Monday and just broke down in the middle of morning report. And we don't talk about mental health days, but I definitely needed a mental health day, and my partners knew that. And it's okay to seek professional help as well. I think there still is this unfortunate stigma that seeing a psychologist or a psychiatrist is some sort of manifestation of weakness, and it simply is not the case. And sometimes the tools that you develop in these sorts of sessions can be very helpful. So just know that there are people that care for you, and that there are always resources out there. We are pretty much at the hour, and I want to give a huge thanks to my colleagues, friends, and partners from across the country for joining us for National Wellness Month. The AAST annual meeting is next month in Atlanta, Georgia. There's also a virtual meeting as well for those who can't make it. If you have any questions, feel free to get in touch with us. And again, the archived version of this Grand Rounds should be available on the website by next month. Next month, no Grand Rounds, AAST. Thank you all so much.
Thank you.
Thank you. Bye.
Thank you, everyone. So good to see everyone.
You too.